Hello and welcome, everyone. My name is Kristen Talbot. I'm the program manager for MAVEN Project, and I thank you for joining us for today's session, and our friends at Chota Community Health Services for hosting today's session, A to Z of EKGs with Dr. Charles Schulman. Dr. Schulman was an assistant clinical professor of medicine at Harvard Medical School. He is currently a corresponding member of the faculty of Harvard Medical School and a senior physician at the Beth Israel Deaconess Medical Center in Boston. In addition, he has been practicing non-invasive cardiology since 1970. Dr. Schulman's scientific articles and abstracts have appeared in the New England Journal of Medicine, Circulation, the American Journal of Cardiology, and the British Heart Journal. His research interests include treatment of hypertension, congestive heart failure, and hyperlipidemia, and we are just so very thankful to have him as one of our MAVEN Project volunteers. So Dr. Schulman, when you're ready, please begin.
Okay, well, thank you very much, Kristen, and good morning, everybody. This is the first of 3 talks that I'm planning on the topic A to Z of EKGs. So this one will have the basics and some other things I'll show you in the learning objectives. The usual disclosure is that neither I nor any of the other individuals in a position to influence the content of this activity have any financial relationships. As Kristen said, the MAVEN Project is accredited and designates this activity for one Category 1 credit. And so with that, we'll turn to the learning objectives for this talk. I'll review the anatomy and blood supply of the cardiac conduction system, explain and expand on the formation of the clinical EKG, and talk about approach to reading an EKG, rhythm, bundle branch block, and heart block. The second talk in the series is about atrial and ventricular arrhythmias, and the third talk is about ST and T-wave abnormalities. To start, here's Dr. Einthoven, the man who invented the EKG machine. And here's a picture of a man having one of Dr. Einthoven's EKGs with his 2 hands in buckets of saline. In a recent article in Circulation entitled the Electrocardiograph at 100 Years, there's a picture of what this machine looked like in 1905, again with the patient and his hands and foot in buckets of saline. Just to show you how very far we've come, in 2024, we're now able with consumer watches to record EKG data, to gather it on an ECG dashboard, and AI analysis allows for the determination, or at least the prediction, of left ventricular pump strength based on the analysis of the current EKG. So here we are 100 years later. Now, to review the anatomy and blood supply of a cardiac conduction system, as you may remember from medical school, the cardiac impulse starts at the sinoauricular node, the SA node, located in the right atrium at the junction of the superior vena cava. Impulses travel through the atrium to the AV node, located in the interventricular septum, then to the common bundle, then to the bundle branches, and to the His-Purkinje system, where the ventricle is depolarized. The blood supply of these structures is as follows. The SA node is fed in 60% of people from the right coronary artery and 40% from the left circumflex artery. The AV node, on the other hand, is fed in 90% of people from the right coronary artery. The right bundle branch and the anterior fascicle of the left bundle branch are fed by the left anterior descending coronary artery, and the left posterior fascicle is fed by a mixed supply. These blood supply issues have factors when one considers heart block in the presence of acute myocardial infarction. Okay, now the basic concept of EKGs, ECGs in English, EKG in German, is that there's some kind of a reference electrode and an exploring electrode. And when the electrical vector travels toward the exploring electrode and is printed on an electrocardiograph machine, there's a positive deflection. So if you look at the different leads, a positive deflection means that the vector is traveling toward that lead. On the other hand, if the vector is traveling away from that lead, there will be a negative deflection. Now, the cardiac impulse begins in the SA node, which has no, which does not cause a deflection of the surface electrocardiogram. As the impulses travel through the atrium, the next deflection is a P wave, followed by the impulse traversing the AV node, which again is isoelectric. So this is AV node right here or here. And then the QRS represents the His-Purkinje system. The ST segment and T wave are repolarization, and the impulse, the electrical wave, then goes back to the isoelectric baseline. So we have P, QRS, T. This is what's called Einthoven's triangle. This is the limb leads 1, 2, and 3, which are bipolar leads. So they have a negative pole. Lead 1, for example, has a negative pole in the right arm and a positive pole in the left arm. Lead 2 has a negative pole in the right arm and a positive in the foot. And lead 3 has a negative in the arm and positive in the foot. The other foot is a ground. Okay, this forms a triangle. Okay, now the chest leads are located as illustrated here. V1 is to the right of the sternum, and then V2 also is to the left of the sternum, and then V3, 4, 5, and 6 toward the cardiac apex and toward the axilla. The initial deflection of the QRS at the beginning of the QRS travels from left to right, leading to a small R wave in lead V1 here, right? It travels from left to right toward V1 and away from V5 and V6, you see? Oh. Writing a small Q wave. Then the major deflection, right? 3 and 4 are ventricular depolarization, with a deep S wave in V1 and an R wave, R wave in V6. That's because the vector is traveling away from V1 on the right side, traveling in that direction, and toward V5 and V6. This leads to what's called R wave progression across the precordial leads, across the anterior precordial. So the R wave gradually rises from V1 through about V4 or V5, one or the other, but not V6. Okay, so there's gradual R wave progression. We'll talk about poor R wave progression in a couple of minutes. In the frontal plane, that is, with leads 1, 2, and 3. Oh, you know what I didn't tell you is that leads AVR, AVL, AVF are unipolar leads, so that the reference electrode is right in the center. AVR is on the right arm, AVL is on the left arm, and AVF is the foot. We can calculate axis using this information. My suggestion is that, and the way I do it is really the easiest way to do it is to consider leads 1 and AVF. Lead 1 is the horizontal, as illustrated here. Lead AVF is the vertical, as illustrated here. And get a laser pointer, there we go, okay. It's easy to figure out where the axis lies by using these two electrodes. 0 to 90 is normal, or perhaps a little to the right of 90. Left of 0, but really left of -30 is left axis deviation, and to the right of plus 90 or plus 100 is right axis deviation. An axis negative in lead 1 and negative in lead AVF is what's called extreme axis deviation, or northwest axis. This is a picture of the Seattle Space Needle for illustrative purposes. Now, we advise a systemic approach to interpreting ECGs. So the parameters to assess are rate, rhythm, the intervals, the axis, whether or not there's chamber hypertrophy, and whether or not there's ischemia or infarction. So here's an illustration of normal sinus rhythm. P, QRS, right? There's no real Q wave here. So R, S, and T, recovery. And you can calculate, the parameters are that there's a P wave before every QRS. They're identical. And normal PR interval ranges between 100 and 120 and 200 milliseconds. So each small box is 40 milliseconds. This is a blown up view. Each small box is 40 milliseconds. Each large box is 200 milliseconds with a standard paper speed of 25 millimeters a second. So PR interval should be less than 200. The QRS should range between 80 and 120 milliseconds. The QT interval, that is from the beginning of the QRS to the end of the T wave, should be under 470 in women and under 480 in, under 470 in men and under 480 in women. And you can get a sort of a fast estimate of what heart rate is by taking any point on the QRS. One box is a rate of 3. If the next beat is here, that's a rate of 300, 150, 100, 75, 60, 50, and 43. You get the idea. This is a normal ECG. The, the rate is normal. Here, we can calculate the rate right here, right? 300, 150, 100. So the rate is, 75. So the rate is probably 90 on this ECG. The PR interval was normal. The QRS is narrow. The QT interval is normal. And there is, here, notice the R wave progression become progressively larger as you move your electrodes across the chest. Here's another normal one. This has a prominent Q wave in 2-3 and AVF. And we will consider that these are septal, they're called septal Q waves. They're narrow and small. And the difference between a non-Q pathological Q wave is narrow, small Q waves. A pathologic Q wave is deeper and wider. By definition, it is one box in duration. That is greater than 0.03 seconds, 30 milliseconds, and the amplitude and/or the amplitude is 25% of the R wave amplitude. Okay, so here's another ECG. It's normal sinus rhythm. You'll notice that the PR interval is prolonged. We'll talk about that later. And what is the axis in the frontal plane? Well, look at lead 1, positive in 1 and negative in ABF. Whoops, sorry. So positive in 1 puts it on this side of the vertical. Negative in ABF puts it above the horizontal, so it's in here. Left axis deviation. Here's another one. It's negative in 1 and positive in ABF. So negative in lead 1 places it to the left of the vertical, and positive in ABF puts it down here. That is right axis deviation. Okay, now here was a 47-year-old man that I took care of, who had an acute MI, acute inferior MI, incidentally, 5 years prior to the taking of this particular ECG. What's the axis? It's negative in 1 and isoelectric really in ABF, making the axis minus 180. That's a very unusual axis. What do you think caused that? Whoops, 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 whoops. Sorry. So, negative 180 degrees is a very unusual axis. What do you think caused that? Is his heart on the wrong side of the chest? How do you know it's not? Well, you know it's not because
There's a comment that said lead placement.
I'm sorry?
There's a comment that says lead or lead placement. I don't know.
Okay, good. Whoever I applaud whoever made that comment. Okay, you'll notice that R wave progression is normal. And in fact, this is his baseline ECG. you'll notice that the axis here, the QRS, is horizontal, all right, but it's 0 degrees, not 180 degrees. So this is his baseline ECG, and this ECG has indeed reversed arm leads, so that this is really AVL and this is really AVR. And this comes in upside down. So if you have a negative P, negative QRS, and negative T in lead 1, think reversed arm leads. Direction. And I'm going in the wrong direction. Okay. Now, I asked the question, when you hear hoofbeats on the roof on Christmas Eve, what is it more likely to be? Santa Claus's reindeer or a zebra? Zebras are pretty rare to begin with in the United States, although somebody pointed out that in South Africa, I can't use this because there are so many zebras. But calling something a zebra is really talking about it as an uncommon event. So here's a 66-year-old man who presented with a 3-day history of cough, congestion, and pain in his chest. And lo and behold, his axis is exactly the same as the other one, right? Minus 180 degrees. Is this arm lead reversal? And how do you know? Well, if you look at our wave progression, which ought to look like this, in fact, it goes in the opposite direction. The complexes become smaller and smaller as you travel out left of the chest. And the reason that this fellow has this looking ECG is because his heart is located on the right side instead of the left side. A pretty unusual occurrence, but situs inversus or dextrocardia is the cause of this man's weird-looking ECG. Okay, so next we'll talk about bundle branch anatomy, or the bundle branch block. So as I said, there's the HIS or common bundle. It divides into a right bundle and a left bundle, and the left bundle divides into an anterior and a posterior fascicle or division. Sometimes you notice that sometimes the anterior fascicle is pictured here and the posterior fascicle pictured here, and in this illustration it's the other way around. But that's because of the orientation of the fascicles are really forward and back, rather than being able to be depicted in a two-dimensional drawing. Okay, so this is a typical right bundle branch block. This is a typical left bundle branch block. QRS should be greater than 120 milliseconds or 3 boxes, which it is. 1, 2, 3 plus. Here, be wider. 1, 2, 3 plus. Okay, so greater than 120, the QRS duration greater than 120 milliseconds. In right bundle branch block, the initial deflection, the initial depolarization of the ventricular septum is normal. That is, it goes from left to right, followed by an S wave because the impulse travels to the left ventricle. And in the case of right bundle branch block, secondarily toward the right. Remember, V1 is located on the right side of the chest. So this is right bundle branch block because the vector is traveling toward V1. If you look at V6, there's an S wave It's not a deep one, but there is one, and that's the equivalent of this R prime seen in V1. In the case of left bundle branch block, there may or may not be a small R wave, and then there's a dominant S wave. In V1 and in leads 1, AVL, and V6, the impulse looks like this. Okay, so here's an example of patient's ECG with sinus rhythm and bundle branch block. Which one, right or left? Right? Okay. My quick and easy way of diagnosing bundle branch block is to look at lead V1, located here on the right side of the chest. If the abnormal deflection is toward V1, it's right. If it's away from V1, it's left. Simple. In this case, we have the typical RSR prime of right bundle branch block. People have told me that they're confused about the rabbit ears. Typical right bundle will have rabbit ears, but that's not what's important. What's important is where the abnormal deflection is going, where the vector is traveling. Okay, here's another one. Wide complex, QRS is greater than 120 milliseconds. And is this right or left bundle branch block? Well, it's traveling away from V1, that is negative in V1, that is down, that is left bundle branch block. Okay, so right bundle travels toward V1, left bundle travels away from V1. Simple as that. Okay, now here's an asymptomatic 36-year-old man with a very funky looking QRS complex. The QRS complex is wide. You notice it's wide. But there's something funny looking about this. There's a very short PR interval and what's called a delta wave, a slurred upstroke to the beginning of the QRS. Do you know what this is? Is this bundle branch block? Here's another one. Similar. Okay. Slurred upstroke, short PR interval. This is WPW, or Wolff-Parkinson-White syndrome. It's pre-excitation. There's a bypass tract, an accessory pathway, and a bypass tract, so that the explanation is that normal impulses travel through the AV node down the common bundle, and so you have a QRS that looks like that. Whereas with WPW conduction, the impulse travels down the bypass tract and writes this delta wave. It gets there early, in other words. Okay, and here's a picture of Doctors Wolff, Parkinson, and White. Dr. Wolff was on the staff at Beth Israel Hospital in those days. Dr. Parkinson is from London. Dr. White is Paul Dudley White, who was one of the founders of the American Heart Association, and for whom the bike paths along the Charles River in Boston are named. He was an early advocate of exercise and healthy living. Okay, now turning to heart block, and we have the heart block poem, one of my favorite poems. If the R is far from P, then you have a first degree. Longer, longer, longer drop, then you have a winky bop. If some P's don't get through, then you have a Mobix 2. If P's and Q's don't agree, then you have a third degree. So we'll look at examples of all of those things. So here's first degree AV block, or what's more common, what it's more commonly called today is AV delay, not really block. But there's one-to-one conduction. Every QRS is preceded by a P wave, and the PR interval is greater than 200 milliseconds, and it doesn't change. Okay, here's another one with an even longer PR interval, such that the P wave is almost on top of the preceding T wave. Okay, now in second degree block, some beats are conducted and some are not. So we have two examples here of rhythms where some beats are conducted and some are not. So the first thing you do is you march off the P waves and determine that the distance from here to here to here to here these distances are all the same. Well, similarly in this one, here to here to here to here to here, the PP intervals are all the same. In this one, so this beat is not conducted, this beat is not conducted, nor is that one, nor is that one. Which one of these patients needs a pacemaker, A or B? Anybody want to answer in the chat?
B, lots of
B.
B.
Okay, you guys are right. You guys are on the ball. A is an example of Wenckebach type of AV conduction. The PR intervals lengthen before the drop beat. So here's this PR interval, here's this longer one, and here's a drop beat. Whereas in this example, which is called Mobitz 2 conduction, all of the PR intervals are exactly the same. This is all or nothing conduction. It either conducts or it doesn't. And so all the PRs are the same. Hello. Okay. And this illustrates Wenckebach conduction. It was Dr. Mobitz in 1924 who recognized the difference between this and what's now called Mobitz 2. So this is also called Mobitz 1, or it was originally described by Dr. Wenckebach in 1899 before the introduction of the electrocardiogram, interestingly. And so there's an incremental PR increase, 210, these were in milliseconds, 210, 380, 540, drop beat. Okay. The distance from this R wave to this R wave is less than two times the RR interval of the conducted beats. You'll also notice that because the increment of increase it decreases, right? It's decremental conduction, right? So PR interval of 210, 380, 540. The difference between 210 and 380 is 170. The difference between 380 and 540 is 160. Thus, the RR intervals become smaller. Okay, that's a clue to Wenckebach conduction. There are many forms of Wenckebach conduction. I won't really go into them, but it's important to know that Wenckebach conduction takes place in the AV node. So this is an AV nodal phenomenon, and is a matter of relative refractoriness of the AV node. Okay, here's Mobitz 2 conduction. All of the PRs of conducted beats are exactly the same. You see, so here there's either 3 to 2 or 2 to 1 conduction. The atrial rate itself is constant, and the PR intervals are all constant. Mobitz 2 conduction occurs in the bundle branches, not in the AV node. So this is organic, whereas Wenckebach is functional. Now, one way to tell the difference between Wenckebach and Mobitz 2 is to exercise the patient. So here's a 69-year-old man that I took care of who presented with chest pains on exertion, so he underwent a stress test. And here's his rhythm. This was his rhythm for years. This PR interval, longer PR interval, drop beat. Okay, so this is Wenckebach conduction. And what happens when he exercises is that conduction improves. And that's a characteristic of Wenckebach conduction. And is that exercise or atropine improve conduction. This is the consequences of Mobitz 2 AV block, which is why that second patient needs a pacemaker. So their PR intervals are all the same, and then conduction stops for a long time. Some seizure-like activity is going on here, I think. When conduction resumes, the PR interval is still exactly the same. But this is why we put pacemakers in people with Mobitz type 2 block. Okay. Third degree AV block, or also called complete AV block, has no relationship at all between the P waves and QRSs. So as illustrated here, the arrows show the P waves, and you see them marching right through with no fixed relationship to QRS. Here's another example. P, is a, and this is an escape rhythm, pretty slow, 300, 150, 175, 60, 50, 43. So this is an escape rate of 43 beats per minute. Okay, and now I would ask the question, this ECG, is this heart block? Well, let's look. Let's look down here. I think that P waves are, you can see P waves both in lead 2, the rhythm strip, and V1 rhythm strip. Okay, you notice that the PR intervals are all the same as we go along here, and all of a sudden there's a drop beat. But what is it about this drop beat? This is a P wave. Okay, what is it? What is it about this P wave? This P wave is premature. Okay, in order to call this heart block, the P wave would have to be this distance away, would be over here someplace. Okay, so this is a premature P wave, a PAC. And it's not conducted because the AV node is refractory at that time. So this is a non-conducted PAC, one of the commonest causes of pauses. Is a blocked PAC. Whoops. Okay, now here there's an elderly woman who presented with syncope and then chest discomfort. And she has a slow rate as well. Her heart rate is 47. This says the computer read supraventricular bradycardia. Is that true? Not really. If you notice, you can see P waves. They're pretty clear. There's this one. There's probably one buried there. This one. There's probably one buried in there. This one. And the atrial rate is in fact close to a little less than 150, right? 300, 150, less, probably 145, 140, something on that order. Right, so there's really a sinus tachycardia. But you'll notice that the P waves kind of march right through. There's no fixed relationship of P waves to QRSs. So this is complete heart block. All right. Why is this complete heart block? What's causing this complete heart block? Well, there's ST elevation in lead 2, 3, and ABF, consistent with and ST elevation MI. As a matter of fact, this it reads it, possible inferior epicardial injury and how, right? And as an aside, if the ST elevation in lead 3 is greater than lead 2, that implicates the right coronary artery. So what's going on here is that the right coronary artery, which feeds the AV nodal artery in 90% of people, notice here. And so there's right coronary artery ischemia, or there's right coronary occlusion, leading to ischemia of the AV node, which is what leads to complete heart block. In inferior acute MIs, there is there's usually progressive AV block, looks like Wenckebach at some times, leading to third-degree AV block. Usually you do not need to put a pacemaker in such a patient because it recovers when circulation is reestablished. Okay, in that case, I leave you with some advice from Boston for the pandemic.
I like that.
And with that, I thank you very much.
Thank you so much, Dr. Schulman. We do have a question already, but I just want to remind everyone that you can put your questions in the Q&A box or the chat box. I will read them and hopefully not stumble over your big words, or you can use the raise hand feature and speak directly to Dr. Schulman. First question is, can you elaborate what you mean by Wenckebach being functional? I understand Motul is organic because of a structural issue.
Yeah, that's Mobitz 2. That's right. That's degrees functional. Well, functional means that it has to do with AV nodal refractoriness. So if we go back, it's a as the PR interval becomes longer, the next P wave, which turns out to be the drop beat, is dropped because the AV node is refractory. Or so that's a functional block, as opposed to an organic block, where you either have conduction or you don't. Okay.
They said thank you. All right, we'll wait for more questions, and while we do, I will stall by just a reminder that when you close out of this webinar, your CME survey is going to appear in a tab on your browser. Please make sure that you get your everything filled out correctly. So your correct licensure, the email account affiliated with MAVEN Project, today's date, March 27th, and Dr. Charles Schulman is the volunteer speaker today. And also a reminder that if we offer mentoring for all stages, all things, including clinical mentoring, especially for EKGs. We know this is a challenging subject. So if this is something that you feel that you would like to do some one-on-one mentoring with, you're more than welcome to fill out the request. But EKGs, we also do it for CGM, uh, kidney disease, anything that you can think of, we have a mentor. Okay. So if you go onto the clinic portal, you can see all of the community portal, I'm sorry, all the upcoming sessions. Dr. Schulman does have the next sessions coming up. Let's see if I can
I
do this
believe
quick.
June and July.
Is that what it is? I would believe you. We have May 1st, basics and heart block. Then we have June 5th, ischemia and other ST and T wave abnormalities. And July 10th, atrial and ventricle arrhythmias. So, and you can register for those online.
Yeah.
And looking forward to the next talks.
In the other order.
I'm sorry?
I think number 2 is arrhythmias.
Oh, let me know if I need to switch that. I'll do that. Question. Can you please discuss lead placement in patients who have extremity amputations?
Well, you can't put it on the prosthesis. Because that doesn't work. You could place the lead on the most distal part of the extremity. So if you have a below the knee amputation, for example, you can place the electrode just above the knee. If you have an above the knee amputation, you can place it just above that. That's the idea.
Thank you. All right, we'll just pause one more minute to see if there's any more questions. And if they're not, we'll see you at the next sessions. Oh, do you mind reviewing the, Do you mind reviewing the axis figure again? Yes, we have time.
My mind? No,
Yeah.
I don't mind. Let's see here.
And while you're going back, I'm just going to answer one of the questions in the chat about getting a list of lectures where you can register beforehand. Yes, if you go into the community portal, on the top, it will say education sessions or education. It'll say education something. I'm trying to pull it up while I'm talking. If you highlight that drop down, it'll show you all the upcoming sessions where you can register. Yeah, educational sessions. It'll give you the list of everything that's upcoming, the ability to request a session, and it also has the on-demand library.
Okay, so you want to go over axis again?
Yes, and I'm sorry, it said the triangle. I was actually thinking the triangle figure.
You don't mean axis. You mean Eindhoven's triangle.
Yes, that's
sure. This, right?
Yes.
Okay. So these are the bipolar leads. Okay. This is you know what? I don't think I have an illustration of unipolar leads, but okay, with the unipolar leads, the baseline, if you will, electrode is in the center of the body, and it goes to AVR, AVL, AVF. But in Eindhoven's triangle are the bipolar leads. So there's a negative pole. See, with the unipolar leads, this is 0 and positive in one direction or another. These are bipolar leads. So there's a positive and a negative. Lead 1 is negative in the right arm and positive in the left arm. Lead 2 is negative in the right arm and positive in the left leg. Lead 3 is negative in the left arm and positive in the leg. So in lead one, for example, if you have a positive deflection, that means the impulse is traveling that way toward the left arm.
Quick question. With the unipolar leads, which lead is reading as 0 or the center?
All three of the unipolar leads. The 0 is at the center. In the center right here. So it goes from the 0 to right arm to AVR to left arm AVL to left leg AVF.
Okay. Oh, okay. Okay, so there is no actual lead physically in the center of the chest.
No, there is not.
Great. This question made me laugh. Thank you, Dr. Levin, for the chuckle. Can you recommend a good book to have to review all of this? I knew this all half a century ago. And then other comment, would you please go over the access as well? Thank
Go
you.
over access again. Sure. Okay. So there's a 360 degrees into the circle. 0 degrees is the horizontal toward toward lead one. Plus 90 is the vertical toward lead AVF. So toward AVF would be here, away from AVF would be here, toward V1 and toward lead one would be here, and away from lead one would be here. So if you have a 10 millimeter R wave in lead 1, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and you have a 10 millimeter R wave in lead AVF, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and then you drop perpendiculars, and so the axis turns out to be right over there.
Right.
Or I think we have. Okay, so here, this is plus 5, plus 10, plus 14 in lead 1, and minus 5, 10, 15, 16 in lead AVF, right? So, plus 10 puts you over here, and then minus 15 puts you over here. Whoops, sorry. Okay, so the axis is going that way. But using 1 in AVF is really the easiest way to do this.
All right.
Positive in 1 and positive in F puts it here. Positive in 1 and negative in F puts it here. Negative in 1 and positive in F puts it here, and negative in both puts it here.
Great. There was just a comment that said, I think the confusing part is what exactly lead 1 is. I understand now that lead 1 is simply a way of figuring out the direction of the electrical activity from right arm to left arm.
That's correct. Yep, true.
Great. All right, I don't see any other questions, but we still have a couple minutes, so I'll pause and just reminder about your CME survey. And also, if you are interested in mentoring, EKG mentoring, you can request that on the portal. You'll get to talk to me about that. And I also did put the link in for all of the upcoming sessions so you can register. We just have a bunch of thank yous in the chat. So I think that is the end for today.
Okay, wait, before we end, I just want to go back to this. Remember that if the electrical vector is traveling toward an electrode, it's going to write a positive deflection. And if it's traveling away from the electrode, it's going to write a negative deflection. That's the basic principle. And that helps us to understand what's going on. Okay. In which case, I thank you very much. Here's my email address if you want to ask me questions or send me cardiograms. I'm happy to look at them and give you my opinion, as to whether the computer is right or not right.
Thank you so
Because
much, Dr. Schulman.
okay, bye-bye.
Have a great day, everyone.